of the board members of the European section of Andrological Urology and the European section of Urology in office and outpatient clinics are delighted to collaborate and to produce this webinar. Title: Latest Updates on Male Infertility. Things change, and EAU, ESU, and the EAU section office offers education to all the urologists worldwide. I would like to ask Professor Matthias Benjo from Debrecen, Hungary, to give us his knowledge, his opinion, if we have something new considerations on the etiology of male infertility. Matthias, thank you.
Thank you very much. I will start to share my screen right now, and I will start my lecture. So, I'm very honored to have this lecture and invited by the EAU itself. I have no potential conflict of interest to report. The primary objective of this lecture is to provide practical overview of the most important causes of male infertility. I won't be able to cover all possible causes as much as I would like. This interpretation will be quite like the practice at my own office. The thorough andrological evaluation of couples requires precise assessment of the males, including the detailed history of the patient. By being precise at the beginning, many possible causes can be detected during the first few minutes of the consultation. Of course, this requires in-depth knowledge of the etiology of male infertility. When I register the patient's history, I usually take major events of patient's life, including brief family history, events around birth, puberty, onset of sexual activity, current sexual habits, general diseases, lifestyle, body parameters, history of female partner, presence of urological symptoms, actual infections, including COVID history. This is the start, but as you can see, I get a ton of information before even touching the patient. So in this lecture, we will do the same and discuss the major possible causes of male infertility, trying to apply the chronological order. At the time of conception, genetic factors will determine the health of the offspring. If there are carried genetic abnormalities of the parents, it will affect the whole embryo development. Major genetic disorders will lead to miscarriage, but there are cases when a healthy male offspring can be born with hidden genetical changes leading to late detection of the disorder. Klinefelter syndrome is a common cause of male infertility, especially among patients with azoospermia. It is very important to identify patients with these changes, especially before performing any assisted reproduction technique, since the likelihood of unbalanced chromosomes in the offspring is increased. Miscarriages, congenital malformations in family history, or severe infertility of the patient can be the indication for chromosome analysis. Testes of mammals require lower temperature than body health for proper functioning. Testes develop at the region of the kidneys, and this is due to hormonal and anatomical changes. At the time of birth, testicular descent is normally completed. Cryptorchidism is the most common congenital abnormality of the male genitalia. At the first age of age, nearly 1% of all full-term male infants have cryptorchidism. It is also a common cause of male infertility, especially among patients with azoospermia. The degeneration of germ cells in mal-descended testes is apparent even after the first year of life, and the number of germ cells declines during the second year. Therefore, if the patient reports testicular or inguinal surgery in the early childhood, that should call our further attention, since late treatment of cryptorchidism may disrupt entire spermatogenesis. Cryptorchidism can be a part of the testicular dysgenesis syndrome. This is a developmental disorder of the gonads caused by environmental and genetic influences early in pregnancy. Besides cryptorchidism, TDS includes hypospadiasis, reduced fertility, increased risk of malignancy, furthermore Leydig and Sertoli cell dysfunction. TDS patients may require closer follow-up due to possible hormonal and malignant disorders during lifetime. Puberty is an important event of the male's life. Spermatogenesis is being initiated, hormonal changes start to develop, onset of the sexual activity occurs. Delayed or especially lack of puberty must warn us potential major hormonal disturbances. Lack of gonadotropins can be the result of genetic disorders like Kallmann syndrome, but acquired causes like after pituitary surgery can also lead to hypogonadism. Early detection by hormonal tests and imaging techniques will offer the possibility of early treatment by gonadotropin and providing normal sexual development. Low testosterone levels can occur during the whole lifetime. Hypogonadism is also the consequence of visceral testicular causes like the previously mentioned TDS, or others like anabolic steroid abuse, sleeping disorders, obesity, or aging. Many of these factors can be easily assessed by evaluating the patient's lifestyle habits. Obesity is linked with increased aromatase activity, decreased gonadotropin release, oxidative stress, and increased temperature of the testes. Varicocele is the condition but also increases temperature and pressure of the testes, leading to hypoxia and reflux of toxic metabolites. Varicocele is present in almost 15% of the normal pair population, in 25% of men with abnormal semen analysis, and in 40% of men presenting with infertility. The incidence of varicocele among men with primary infertility is estimated about around 40%, whereas the incidence in men with secondary infertility can be significantly higher. Testicular germ cell tumor affects the young fertile adults aged from 15 to 40 years. Testicular tumor can be detected accidentally during andrological evaluation or by complaints of the patient. Men with testicular tumor have decreased semen quality even before cancer treatment as a part of the TDS. In addition to spermatogenetic failure, patients with testicular tumor have impaired Leydig cell function, even in the contralateral testis. Azoospermia has been observed in 5 to 8% of men with testicular tumors and oligospermia in 50%. It is mandatory to include counseling regarding fertility preservation prior to any gonadotoxic treatment, since the survival rate is high and it is the most common cancer in men of reproductive potential. Semen analysis and cryopreservation are therefore recommended before gonadotoxic cancer treatment. Treatment of hematopoietic malignancies like lymphoma or leukemia may have similar effects, so cryopreservation should be offered to these patients as well. Some patients with urogenital infections are symptomatic, but there are males who have no symptoms. Assessment of infection of the male urogenital tract must be an integral part of the evaluation of males, since it is potentially a curable cause of male infertility. Presence of bacteria and inflammatory agents may also lead to oxidative stress and DNA damage of the sperms. Not just bacteria, but viruses do harm to testicular tissue. Beside the well-known effect of mumps in adulthood, COVID-19 does appear to impact male infertility. This virus can lead to temporary hypogonadism. The data supports that reduction in testosterone production is more likely associated with indirect testicular damage due to systemic or local inflammation. Obstructive azoospermia is the absence of spermatozoa in the sediment of centrifuge sample of ejaculate due to obstruction. Obstructive azoospermia is less common than non-obstructive azoospermia and occurs in 20 to 40% of the men with azoospermia. Men with obstructive azoospermia usually have normal FSH level, testes of normal size, and epididymal enlargement. Of clinical relevance, men with late maturation RS may present with similar clinical picture. The vas deferens may be absent bilaterally or unilaterally. Obstruction can be due to genetic causes or acquired causes like infection or surgical intervention. As we mentioned previous operations, we must consider immunological infertility occurring due to damage to the blood-testicular barrier. Not just surgery, but testicular trauma or torsion may also expose sperms to the immune system, leading to anti-sperm antibody production. These damage the function of the sperms, requiring assisted reproduction as solution. We have mentioned oxidative stress before. A controlled presence of reactive oxygen species is required for sperm maturation, like capacitation, hyperactivation, acrosome reaction, and spermatocyte-oocyte fusion. Imbalance between reactive oxygen species production and antioxidant capacity results in a high or low amounts of ROS. Overuse of antioxidants may lead to reductive stress as well. So reductive stress can be as harmful as to cells as oxidative stress. Due to many factors which are present in the developed countries, the age of the parents considering having the first offspring is increasing. However, males can preserve their fertility to advanced age. Both quantity and quality changes of sperm parameters are observed. The continuous spermatogonia replications mean that more and more copies are done of the chromosomes. The estimated number of copies are 15 at age 15, 308 at age 30, and more than 800 at age 50. The more copies are done, the more mistakes may occur. The definition of idiopathic infertility refers to the condition when clear explanation can be given to the altered fertility status. I don't like really that term because more and more connections are revealed due to many variable publications, including meta-analyses. These include, for example, the previously mentioned lifestyle factors like obesity and smoking. This is the table which summarizes the causes of male infertility in relation with age, mentioning the key points of disease management. So as we discussed during the present lecture, male infertility is usually a complex disorder. Proper knowledge of the potential causes is essential. A thorough andrologist can decrease the chance of setting up the diagnosis of idiopathic infertility and offers a wide range of therapeutical options for the males. Experts have to keep on learning and following up literature to see the latest updates of andrology, like in the upcoming lectures. Thank you for your kind attention.
Thank you very much, Matthias. The lecture was excellent. Definitely, I believe we will receive many questions at the end. And let's move in a domestic trip from Debrecen to Budapest. A very well-known expert, Professor Zsolt Koba, our personal friends from Budapest, extremely active in the field of male infertility and male endocrinology. He is going to give us his thoughts how to salvage a reproductive potential in males with oncological disease, and of course, we will have references when it is relevant to EAU guidelines. Zsolt, thank you very much.
Dear Nicholas, thank you very much for the kind introduction. And so let's start with my lecture. So I have also no conflict of interest to report. And the title of my talk is today, Salvaging Reproductive Potential in Males with Oncological Disease. So let's see at first a little bit in the past, because Confucius said that to study the past if you would define the future. So the past and the history of my talk today that started in the 18th century, where Lazzaro Spallanzani, he observed that the stallion sperm become motionless to the freezing in winter and motility returned back on warming. In 1866, Paolo Mantegazza gave the first prediction about the future existence of sperm banks. In 1949, Polge and his co-workers, they did the first cryopreservation of the human sperm. In the 1950s, that was the first report of the use of frozen and thawed sperm. And from the 1970s, the sperm cryopreservation has been used widely. What are the effects of a cancer, of the malignant diseases of the testicular function? So at first, they can attack the hypothalamus pituitary axis, and they can damage it and affect the gonadotropin production, which results in primary testicular failure. But they can also attack the Leydig cells, and the Leydig cell damage will cause reduced testosterone production and delay or arrest of the puberty in lower age boys. The Sertoli cells are also harmful with the cancer, and the cancer can damage the Sertoli cell function, which will cause impaired spermatogenesis, loss of the germ cells, and decreased size of the testicular volume. And please note that the seminiferous epithelium is really more sensitive. And not only the cancer, then also the anti-cancer treatment can affect the testicular function. Cancer itself may impair fertility, and anti-cancer treatment may be detrimental in all stages of life. It also can cause persistent and long-lasting damage to the germ cells, to the somatic cells, the germ cell survival, the maturation, Sertoli cells, Leydig cells, and also the testosterone production. The degree of the damage depends on the type of a cancer, the type of the treatment regime, the age of the patient, and the fertility status at the time of the diagnosis. Please look at this figure at the side of this slide. Then we can have here risk factors for the different anti-cancer treatments. We have low risk, intermediate risk, and also high risk substances which can damage the testicular function. So the significantly depleted number of spermatogonia can be seen after alkylating therapies and hydroxyurea treatment. So that's why we can recommend fertility preservation before initiating alkylating agent therapies. What are the methods for fertility preservation? The classical way and the traditional way is the semen cryopreservation, which is routinely used in adults. And this is the first line option in adults and also in adolescent ages. The other alternative options, they are the testicular tissue and the spermatogenic stem cells cryopreservation. We can perform surgical sperm retrieval, even when the semen recovery is not possible. Slow freezing or vitrification of immature testicular tissue can be also an option. There is a research-based drug therapies to reduce the impact of chemotherapy. We can shield the testis from radiation treatments, and also some trials report the co-administration of immunomodulating compounds during cyclophosphamide treatment. Let's see the different age groups in the male lives. What to do? In prepubertal boys, they are too young to produce semen samples. The testicular tissue can be frozen at this, before the start of the cancer treatment. Spermatogenic stem cells can be collected due to surgeries, and this can be used for autologous transplantation later on, or for xenotransplantation, for xenografting, or for in vitro spermatogenesis. But please don't forget and remember always that these are experimental strategies and no pregnancies are reported recently. These are all experimental options. By the pubertal age, cryopreservation can be started, can be tried, and so no clinical parameter can accurately predict that the patient will have a sperm or not. The cryopreservation have mature testis protocol and immature testis protocol. We can surgically remove testicular tissue, and so this intervention should be combined with other operations requiring or interventions requiring anesthesia by this boy. The peripubertal boys from the age of 12 years, the testicular tissue should be frozen in conjunction with sperm freezing, but this is a debated issue and also still experimental. What about the adolescents? The adolescents, masturbation may be difficult in this age, so the production of the semen sample. And so mature sperm begin to appear during the puberty, and these can be suitable for freezing, for cryopreservation, which is most feasible in boys when they are older than 13 years of age. The semen can be cryopreserved for adolescent boys in more than 80% of the cases. The methods of sperm retrieval, masturbation, when it's not working, then vibrostimulation or electroejaculation can also be used, and surgical methods like testicular sperm extraction and most recently the microteaser. We have also some additional options from the epidermis and from the testis with a low volume of materials. The teaser, testicular sperm extraction with cryopreservation, that is very important to know that all patients should be offered semen preservation, and by the EAU recent guidelines, we can recommend it before the orchiectomy when it's feasible. When it's not arranged before the orchiectomy, it should be undertaken before the chemotherapy or the radiation therapy. By ejaculation disorders, we can use medical treatment or interventional treatments. In the case of testicular germ cell tumors, azoospermia, the cancer diagnosis we heard from Matyas, that is approximately 8 to 10%. The oncoteaser contralaterally gives us a sperm retrieval rate of near to 40%, but when you perform oncoteaser both contralaterally and so bilaterally, the sperm retrieval rate can be at 80%. Most recently, the highest sperm retrieval rates were obtained following microsurgical techniques when we compare sperm retrieval rates with microteaser to conventional teaser. The microteaser gives us the higher percentages. The fertility preserving methods are then, in conclusion, cryopreservation of the semen as classical way. When we have no semen, then we can surgically procedures use for harvesting sperms from the testis, and microteaser results in higher sperm retrieval rate. The success of fertility preservation depends greatly on the early treatment plan application. Alternative methods are still experimental, and we have concerns about carcinogenesis and epigenetic changes in the offspring. The interventions to preserve fertility should not raise unrealistic expectations, and obtaining informed consent from the parents from younger guys, it's very important. When you look at this flowchart, this summarizes briefly what I told you at this talk. And so the cryopreservation is the main goal of the treatment before, when it's feasible, before the anti-cancer treatment. Infertility is a cause of decreased quality of life after 10 years of the diagnosis by the survivors. And receiving counseling from fertility specialists gives us higher scores on quality of life questionnaires. So that's why the European Society for Clinical Oncology and also the American Society of Clinical Oncology recommends us that physicians should discuss the risk of infertility with all patients of reproductive age diagnosed with cancers. Ladies and gentlemen, thank you for your kind attention.
Zsolt, for one more time, you offered us knowledge and an excellent lecture. Thank you very much.
Thank you very much.
And dear colleagues, it is an honor for me to ask Assistant Professor Marie Dikkelman-Smit from Notre Dame, Netherlands, to give us an insight on the EU guidelines for the pharmaceutical management of male infertility. I was always jealous for my colleagues who were experts on erectile dysfunction because they had to say many things on pharmaceutical management. But Marie is going to say to us, to express her opinion on a role of pharmaceutical management for the alleviation of male infertility. Marie, thank you very much.
Thank you very much for the introduction and the high hopes that you are giving participants that I will answer many questions. Okay, good. Well, it is my honor to discuss the pharmaceutical management of male infertility with you today. And I have no conflict of interest to report. I would like to disclose that I recently joined the panel of the EU guidelines for male sexual and reproductive health, and that I am a board member of the EU section for andrological urology, and a proud one, and that I'm a part of a Dutch multidisciplinary working group that is to revise a Dutch male infertility guideline. The scope of this 10-minute talk is to discuss considerations and background information and the evidence that led to the recommendations made in the guideline. Let's first start with an overview of hormone stimulation regimens to treat endocrine disturbances. Some of that were already discussed in the first lecture by Professor Bagnot. We'll discuss disturbances based on gonadotrophin-releasing hormone deficiency leading to infertility, so hypogonadotrophic hypogonadism, infertility induced by prolactinomas. We'll briefly touch upon that, and treatment options to induce or increase spermatogenesis in primary testicular failure, as reflected by hypogonadotrophic normal or hypogonadism, or its most severe form, obviously the non-obstructive azoospermia. So the clinical features of hypoman can be delayed puberty, as was previously discussed, undervirilization. Anosmia might be a clinical feature in men with Kalman syndrome, so the inability to smell, although that doesn't always have to be the case. Hypo patients can co-present with bilateral cryptorganism or small or micro penis that can be present in young childhood. And obviously later in life, in adolescent age or after hypogonadal symptoms. So I've listed the diagnosis associated with with gonadotropin release hormone deficiency here. And as was already discussed, also the pituitary disease diagnosis that you might encounter following pituitary surgery, irradiation, infection, but also infiltrative disease that involves the pituitary gland. And obviously, the most often you will find low gonadotrophins in men. It will be in men who have abused anabolic steroids. So to induce endogenous testosterone production and spermatogenesis, you can start gonadotrophin therapy. You can prime the Leydig cells with an LH analog, such as HCG, 15 units 3 times a week. And once the synthesis and the release of testosterone from the Leydig cells is initiated, then testosterone can support normal spermatogenesis. So you can wait with FSH injections until testosterone levels have reached normal levels again, and then use either AMG or recombinant FSH to accelerate the spermatogonial maturation. Now, induction of spermatogenesis in this matter is successful in the majority of patients. Conception is also very common, although testicular size when you initiate this treatment is associated with success, and response is not dependent on either a congenital or acquired etiology. Induction may take a long time, so 12 to 18 months, but it is worth it because your patients will be able to impregnate their partners by themselves in many cases. So if by 18 months you have normal testosterone levels for quite some time, but no spermatogenesis induction and a persistent non-obstructive azoospermia, then you can consider and offer your patients testicular sperm extraction. So longer duration of testosterone replacement therapy, as you might see in adults who've been using testosterone for a long time, might or might not be associated with a poor response, and mini-puberty or puberty induction in childhood with gonadotrophins might be of benefit for future fertility potential, but there's no real clear recommendations here. So if we then look at the recommendations in the guideline, they're very clear with strong rating. So spermatogenesis induction in these diagnoses is very successful, and you should really either be familiar with this or refer to an endocrinologist who can do this for your patient. Gonadotropin releasing hormone therapy should be pulsatile, is more expensive, and it doesn't really offer any further advantages. So then on the topic of hyperprolactinemia, that may occur due to micro or macroadenomas as part of genetic syndromes in cellular or paracellular lesions or tumors. The clinical features, they might involve hypogonadism and related sexual dysfunction and oligospermia. So in large tumors, your patient may be complaining of bitemporal visual field defects. Just a note, so galactorrhea, so the loss of fluid from the nipples is very rare in males. Now, true hyperprolactinemia is actually ×2 the upper limit of your laboratory, and macroprolactinemia, you should be a little bit more aware if you have 10-fold increase prolactin levels. Now, hyperprolactinemia can be treated with dopamine agonists, so cabergoline is used most often. They can lead to prolactin normalization and shrinkage if it is based on a tumor, and alternatives, of course, are surgery, radiotherapy, or temozolomide. it is really important to realize that true hyperprolactinemia needs your critical diagnosis and your understanding of this area. So repeat measurements in women with as little as 30-minute intervals have shown that there's high variability in prolactin levels. So stress, even from a venipuncture, from smoking, marijuana use, orgasms, or nipple stimulation can increase prolactin levels. Also, chronic renal failure or drug-induced hyperprolactinemia are very common. And of course, first line of treatment is their discontinuation of the drug. So be aware of how prolactin is assessed in your hospital, and if you're unaware, discuss with your clinical chemist how he or she excludes false positives of inactive macroprolactin, because it's estimated they can be a cause of the hyperprolactinemia that is measured in serum in over 10% of cases. What is really difficult is that the interplay between the spermatogenesis and prolactin is really poorly understood and may actually be very mild. So the dopamine agonists can be used to treat it, but if it really improves sperm parameters is unclear. So the guideline gives you a clear recommendation, but weak one. And consider also that dopamine agonists can give side effects, including nausea and rare side effects such as vomiting, headache, dizziness. But also induction of impulse control disorders. So do not start it on a one-time measurement of a slightly high prolactin just to increase sperm parameters. So always a very controversial topic is hormone stimulation in hypogonadotrophic normal or hypogonadism, unexplained infertility or idiopathic infertility that was already touched upon by the previous speakers. Also neoadjuvant stimulation before testicular sperm extraction in non-obstructive azoospermic patients, either with or without Klinefelter, is very controversial. So that led to very clear recommendations of the EAU guideline that there's no conclusive recommendation for the use of gonadotrophins, of SERMs, either steroidal or non-steroidal aromatase inhibitors. Now, I know this is widely used and very commonly published, but please be aware that the evidence is not there yet. In men with idiopathic oligospermia and FSH values within the normal levels, there might be some benefit from FSH treatment, although clear selection criteria for which patients to treat are not given, and the recommendation is therefore not very strong. So just as controversial, but as commonly applied in clinical practice and was already discussed by Professor Benio, the oxidative versus reductive stress and the widely used also by patients, even if they haven't seen an andrologist or urologist yet, is the antioxidant therapy. There might be a role for unexplained infertility, varicocele, or oxidative stress associated infertility, but especially oxidative stress measurement can be very difficult. Same holds true for men who are diagnosed with high sperm DNA fragmentation, so increased SDF, where antioxidants are very commonly advised. But now let's look at the evidence in the next couple of slides, because they're very contradictory results from randomized control trials, especially in the improvement of sperm parameters, including sperm DNA fragmentation, and also if there is a benefit in what is really the most important thing for patients, live birth rates. So the most recent Cochrane review analyzed 90 randomized control trials comparing 18 different antioxidants with placebo. So there's a problem there as well, that multiple antioxidants are used in various combinations. Eventually, the Cochrane led to an evaluation of a total population of over 10,000 men, and the evidence was current up to February 2021. And they concluded that there's very low certainty evidence from only 12 small to medium-sized randomized controlled trials that antioxidant supplementation might improve live birth rate. And there's only low certainty evidence that suggests that clinical pregnancy rates may increase. So overall, they state that the current evidence is inconclusive as to poor quality of studies that could be evaluated. Now, a little more up to date, but only 5 months more of research was included in this recent systematic review and meta-analysis. Their conclusion actually is the same, but specifies a little bit more precisely, and maybe more for urologists, a little bit more to understand. Effects in men with idiopathic male infertility and men with infertility after varicocele repair, that there might be some low to moderate evidence for positive effect in terms of spontaneous pregnancy rate and in terms of conventional sperm parameters. Again, the way you measure oxidative stress, so either in total antioxidant capacity or other assays, the evidence there is very, very low. Like other male infertility guidelines around the world, the EAU recommends that at this time there's no clear recommendation to be made in the treatment of patients with idiopathic infertility regarding use of antioxidants. To conclude, antibiotics or antiviral therapy, I think that should be in your armamentarium for pharmaceutical treatment of male infertility as well, and be aware that infections of the urogenital tract might need treatment, although they can improve sperm quality, doesn't necessarily improve the probability of increasing conception. I thank you very much for your attention, and I hope that this quick overview is of benefit for you in your clinical practice, and hope to answer your questions. Thank you.
Marie, we really enjoyed your lecture. You gave us clinical messages touching the EAU guidelines, and this was very important, I believe, for the audience. Thank you very much. I would like now to welcome the lecture of Professor Fotios Dimitriadis from Aristotle University, Thessaloniki, Greece. He is the chair of the European section of Urology in Office and Outpatient Clinic. He is the chairman of the Andrology section of the Hellenic Urological Association. Fotios, what new in the etiological and symptomatic surgery in males with primary testicular damage?
Well, thank you very much. Thank you very much for the kind invitation, first of all, and your kind words. Dear ladies and gentlemen, good evening. So, first of all, I need to say that I do not have any conflict of interest. When we talk about etiological surgery in men with primary testicular damage, we mainly have in mind varicocelectomy. Well, what can I say about varicocelectomy? Well, varicocele repair has been a subject of debate for several decades. Finally, it appears that men with only clinical varicoceles has shown that the surgical varicocelectomy significantly improves semen parameters, including also in cases of azoospermia, hypospermatogenesis, or late maturation arrest. Pain resolution will disappear in 48 to 90% of the patients, whereas higher grade of varicocele seems to have a better result. Patients with subclinical varicocele, on the other hand, and patients with normal semen parameters and clinical varicocele appear not to benefit from varicocele repair. On the other hand, in patients with clinical varicocele and abnormal semen parameters, pregnancy rates and standard semen parameters will significantly improve. Also, couples with unexplained subfertility and male with varicocele also may benefit, as varicocele repair will increase the chance of spontaneous pregnancy. Regarding the prophylactic varicocelectomy now, in adolescents, it can be advised the varicocelectomy only when we have documented testicular growth deterioration. In cases of azoospermia, also in these cases, varicocelectomy may lead to sperm appearing in the ejaculate in men with azoospermia. But we need to pay attention here. If this happens, then we have to advise immediately the men to cryopreserve the sperm, because there is a great risk to disappear again the spermatozoa from the semen. However, the varicocelectomy in this group of patients will act beneficially to the sperm retrieval rates and to ICSI outcomes as well. In cases of hypogonadal men, they also will benefit from a clinical varicocele repair, because it seems that mean testosterone, peripheral testosterone, will increase significantly. Also, varicocelectomy will improve sperm DNA integrity, and this improvement seems to be independent from the assay of measured of the DNA integrity or the surgical technique performed. Varicocelectomy might be more beneficial in men with elevated baseline SDF values, however. That is more than 20%. So there is now increasing evidence that varicocelectomy may improve DNA fragmentation and outcomes from ART. As a consequence, more recently, it has been suggested that the indications for varicocele intervention should be expanded to include men with raised DNA fragmentation as well. The dilemma remains, however, as to whether varicocele treatment is indicated in men with raised DNA fragmentation and normal semen parameters. Well, we have few techniques to repair varicocele, clinical varicocele. However, the microsurgical varicocelectomy appears to be the most effective, as it seems to have probably improves pregnancy rates slightly more compared to other surgical techniques, with fewer complications and lower recurrence rates compared to other techniques. However, this procedure requires a microsurgical training. So regarding the varicocelectomy, we have to deliver the testis in order to visualize the spermatic cord, the external spermatic vessels, and the gubernaculum vessels. Then we open the tunica of the spermatic cord. We identify the vas deferens with its vessels. We identify the spermatic arteries, and then we dissect all the internal spermatic veins. This is how it appears under magnification: a spermatic vein, which is dark and opaque, in difference in comparison with a lymphatic vessel, which is clearly transparent and should be spared together with the vas deferens and the arteries. So at the end, we have this result. Now, as we move to the symptomatic surgery in men with primary testicular damage, we mainly should go directly to the testis with fine needle aspiration mapping, with TESA, with conventional TESE or micro-TESE. Fine needle aspiration mapping technique is performed under local anesthesia in the office, and percutaneous aspiration is performed with a 23G needle. In multiple sites ranging from 4 to 18, depending on the size of the testis, the retrieved tissue is sent for a cytological and histological evaluation to provide information on the presence of mature sperm and on testicular histological pattern. FNA requires, however, a secondary therapeutic surgical approach, which may increase the risk of testicular damage, and without appropriate cost-benefit analysis is not justifiable. So FNA mapping cannot be recommended as primary therapeutic intervention in men with non-obstructive azoospermia. Regarding TESA, it is a minimally invasive office-based procedure as well, in which testicular tissue is retrieved with a biopsy needle under local anesthesia, with a sperm retrieval rate ranging between 11 and 60%. Data have shown that using larger needles, 18 to 21 G, with multiple passes could yield a higher chance of positive sperm retrieval, and the complications are uncommon, mainly include minor bleeding with scrotal hematoma and postoperative pain. A meta-analysis including data from a case control studies reported that TESA has 2 times more likely to result in successful sperm retrieval as compared with TESA. So TESA is no more longer recommended in men with non-obstructed azoospermia as first-line symptomatic treatment. Now we go to the heavy weaponry of symptomatic surgery in men with primary testicular damage, that is conventional TESA and micro TESA. Conventional TESA requires a scrotal incision and open biopsy of the testis. The sperm retrieval rates here are about 50%. Observational studies have demonstrated that multiple biopsies yield a higher chance of sperm retrieval, as it was for TESA as well. Conventional TESA has been associated with a higher rate of complications compared with other techniques, that is intratesticular hematoma mainly, and testicular fibrosis secondly. In 1999, Schlegel pioneered the use of microtesticular extraction of sperm approach. A first meta-analysis favored micro-TESA with 52% sperm retrieval rate against 35% of sperm retrieval rate for conventional TESA. However, a second, more recent meta-analysis showed no differences. The difference in surgical sperm retrieval outcomes between these two meta-analyses may be explained by the data studied, but it is important to note that all studies comparing conventional TESA and micro-TESA have shown that micro-TESA is superior in retrieving sperm. The probability of finding vital sperm at TESA varies also according to testicular histology. So men with Sertoli cell-only syndrome will have higher sperm retrieval rate if we go with micro-TESA. Furthermore, the current data suggests that micro-TESA has less complications in comparison with TESA, and therefore the consensus opinion of the EU guidelines panel is that micro-TESA is the optimum approach for surgical sperm retrieval procedures. So in this technique, the micro-TESA, we usually perform a 2 to 3 transverse incision or a single midline scrotal incision or through to dartos muscle and tunica vaginalis. Then we deliver the testis. We perform a full-length equatorial incision and opening of the testis under magnification. And then we inspect of the testicular tissue under microscope vision, 20 or 25 magnification. We identify the main subtunical arteries and their intertesticular ramification. Then we identify the seminiferous tubules nearby the arterial branches, make a blunt microdissection between the septa of the testicular parenchyma to expose multiple areas. This is in the black arrow how appears a good quality of spermatic tubule, whereas in white arrow, with the white arrow, you can see the bad quality of spermatic tubules. Then we identify them and pick up them with a tool, and then we suture the testis. The complications are rare. We have intratesticular hematoma, pain, swelling, infection, and hydrocele. Fortunately, all these complications resolve spontaneously without compromising testicular function. However, the extraction of a large volume of testicular parenchyma may lead to transient or permanent decrease in serum testosterone levels, so we have to follow up these patients. And keep in mind 3 main goals. First of all, the acquisition of an adequate number of sperm, the retrieval of highest quality of sperm, and minimizing the damage. These three goals will guide us to choose the right technique for the right patient. Thank you very much. Now, I have the honor to present Professor Sofikitis to tell us about the new knowledge on the effect that may have the spermatozoa after the post-fertilization effect, after the post-microthese and ICSI, the role in the world of assisted reproductive technology for the management of non-obstructive azoospermia. Professor Sofikitis is known in this field. I think I don't need to represent him because he's already quite world known. Professor Nicholas, please.
I would like to thank very much the European Association of Urology, the European School of Urology, the EAU Section Office for giving to us today the possibility to discuss with you today the period after ICSI techniques, the dreams in the world of assisted reproductive technology. Ooplasmic injections of early haploid male gametes represent a target for future clinical trials. Initial successful results have been reported. Haplodization of chromosomally diploid foreign DNA male germ cells represents additionally an attractive target for clinical research. Development of an artificial testis, an in vitro culture system where diploid male germ cells can be transformed into haploid male germ cells. Genomic editing techniques will be an important chapter for the future. Genomic germ cell transplantation efforts and haplodization of somatic cells again represent targets that need to be further evaluated, and additional research and clinical trials are absolutely necessary. Within the human testis, the larger cell is the primary spermatocyte, metaphase 1 stage, diameter 22 to 24 micrometer, secondary spermatocyte, the product of the first male meiotic division, 12 micrometer, around spermatid, the product of the second male meiotic division, 8 to 10 micrometer, characterized by a Golgi apparatus attached to the nuclear membrane. All of us, we have seen diagnostic testicular biopsy indicating Sertoli cell-only syndrome. However, meticulous mincing, either mechanical or chemical digestion related mincing, may reveal few round spermatids or even elongating spermatids that can be further cultured and processed for assisted reproductive technology. Efforts to create an artificial testis are very exciting. Efforts to develop an in vitro biochemical system where diploid male germ cells will be transformed into haploid male germ cells may represent an attractive mode of treatment in the future for the alleviation of infertility in the subpopulation of non-obstructed azoospermic men in which there is a lack of haploid male germ cells in the testicular biopsy material. Interaction of spermatogenic cells with somatic feeder cells or xenogenic feeder cells or vero cells in co-culture systems represents an approach that have been employed in many laboratories in order to generate haploid male germ cells from the culture of diploid male germ cells. And exciting research refers to the induction of both the first and the second male meiotic division within the cytoplasm of oocytes. Looking in culture systems, generation of step 2 round spermatids, 2 proacrosomal granula attached to the nucleus membrane, are possible to be observed after culture of step 1 round spermatids. Step 1 spermatids are negative for proacrosomal or acrosomal granula. So in vitro culture has the potential in appropriate biochemical mediums to generate step 2 round spermatids or step 5 round spermatids from the culture of step 1 round spermatids. The developmental potential of elongating and elongated spermatids has been observed in vitro culture systems, and actually studies in Portugal's laboratories have indicated the generation, the development of elongating spermatids with a tail length of 20, 30, 40 micrometers after culture of round spermatids without any degree of elongation. Pregnancy rates are anticipated to be higher after ooplasmic injections of elongating spermatids. In Japan, birth of 90 babies has been reported after ooplasmic injection of in vitro culture early haploid male gametes. Clinical applications of culturing male germ cells involve therapeutic management of non-obstructive azoospermia and salvaging reproductive potential in patients with any kind of oncological disease. Germ cell transplantation techniques open a new window for generating haploid germ cells such as hamster round spermatids after transplantation of diploid germ cells such as hamster spermatogonia into the seminiferous tubuli of a recipient testis such as rat testis. Genetic risks should be considered because most of the embryos produced after ooplasmic injections of spermatids that have been generated in vitro demonstrate sex chromosomal abnormalities. Attention is necessary. Epigenetic risks involve a defect in the capacity of the male gamete to activate the oocyte to induce female pronucleus development and extrusion of the second polar body. Defects in the spindle within the oocyte that is generated by the male gamete, and also inappropriate condensation of the nucleus of male gamete. So these are epigenetic risks after assisted reproductive technology using in vitro generated male haploid germ cells. Ooplasmic injections of secondary spermatocytes may have a role in the treatment of specific subpopulations of non-obstructed azoospermic men, oocytes with 2 pronucleate states, normally fertilized oocytes, first and second female polar body can be observed. Human newborns have been reported after injections of secondary spermatocytes recovered from non-obstructed azoospermic men. The future may be testicular biopsy in non-obstructed azoospermic men or in men with genetical cause of male infertility, freezing of seminiferous tubuli or testicular tissue. Nuclease act, remove the genetic defect, and then the cells may be again auto-transplanted within the testis. Transferring cells may be possible with an ultrasonographically guided approach into the rich testis, and another autotransplantation technique may refer to the microinjection of the donor cells through two needles under the control of micromanipulator into the seminiferous tumuli. We need many more research efforts to clarify all these issues we discussed today. I would like to thank very much all of my colleagues today for participating in this webinar. Thank you very much.
Well, that was a very, very interesting session. Professor Sofakidis, thank you also for your very interesting lecture. Now we can go for some questions from the audience. We have a first questions. It is mainly applied to me, but everybody from the panel can answer. It says, what is the effectiveness of the treatment of varicocele in isolated teratozoospermia, isolated astenospermia, and infertility, given the absence of female factor infertility? Well, here I would say that we can go directly with varicocelectomy, because we will have beneficial effects on astenospermia. This is more than sure. And then with teratozoospermia also, except maybe from very, very few cases. I would name one. This is globozoospermia. Maybe there we do not have very good results. This would be my answer. If somebody else from the panel would add to it.
Photios, this is an excellent answer, and this is the EAU policy. Just let's remember 2 years ago, AUA in the guidelines claimed that we in isolated teratozoospermia and presence of varicocele, varicocelectomy was not indicated. But in Europe, we go forward. We have different attitude than the North American colleagues in this issue.
Marie, did you want to mention something about that?
Yeah, thank you, Photios. Yeah, I agree with your remark. I do want to stress that in isolated teratozoospermia, then varicocelectomy might not be of benefit for patients. And of course, I fully agree, especially if you have isolated teratozoospermia that might have a genetic cause, such as globozoospermia, but also in isolated teratozoospermia with head, neck, or tail defects that are very heterogeneous. I would not recommend to do a varicocelectomy in these cases, just as an addition. Thank you.
And there is another question for you, Marie, and of course everybody else can join. At what age can we start hormone therapy, in particular HMG for hypo in children?
Yes, so thank you for that question. So in the Netherlands, as a urologist and an andrologist, I only treat adult patients, and I do see a lot of younger patients with Klinefelter syndrome or Kalman, but I see them multidisciplinary with the pediatric endocrinologist. And I think it's the same in many countries. So I'm a little bit reluctant to answer this question, because I do think that I have some knowledge here, but it's not something that I regularly do. I do not treat pediatric patients for a start. And I think that from my multidisciplinary team, the age of puberty can, of course, be wide, so it's a wide variation. It can be anywhere between 12 and 16. So I think this is a good discussion to have with your pediatric endocrinologist, and that there's no cutoff that we can state here.
Yeah, I agree. Then we have a similar question open to the panel. Can we state the presence of hypogonadism when we have normal peripheral testosterone levels in the blood and the absence of clinical symptoms, but the presence of impaired spermatogenesis? Would somebody comment on that? I would say that no, we cannot say that.
I also agree with this no, that there's low testosterone levels and only the impaired sperm parameters, that is not a hypogonadism.
Yeah,
you have to consider the testicular volume and then the hormone levels and not only the sperm analysis.
Yeah, I agree. Well, another question is, can antioxidant therapy in case of high levels of ROS replace varicocelectomy? Well, as I speak for varicocelectomy, no, the answer is no here. Of course, it will benefit a little bit, but it will not cure all the parameters from semen analysis. Maybe a combination of those two would be more rational if after varicocelectomy still we have increased level of DNA of DFI. Somebody else wants to comment on this?
Only one comment, that high reactive oxygen species level does not immediately mean oxidative stress.
Exactly.
That we have to remember this.
And not to go too far with that treatment, because then we will create reductive stress, which is exactly the opposite, and it has exactly the same effects on semen parameters. Then we have another question. Is commenting that LH is very expensive in Poland, and so he goes with selective estrogen receptor modulators. And I don't know. This is a good alternative if we have financial issues. Anyone does want to comment on that?
Do you use personally in Greece LH therapies?
Yes, as we use it. We used to use a lot, but then we went short in the market from LH. Now we use some kind of LH. It calls Ovitrel. Well, and it has not so good results as the pure LH, but yes, we use it in patients that they have low testosterone in order to increase the testosterone in the first month, and then we go to FSH treatment. What is the situation in other countries?
Yes, I answered in the chat already that in the Netherlands it's been quite difficult for some time to get your hands on LH analogs, humanly derived. It's unfortunate because it was very cheap. Now we revert to, you can revert, or some might do that, to recombinant LH, which is of course way more expensive and is not officially indicated for this real infertility indication of hypo.
Yeah,
so I agree, and then we also use the Ovitrel, but Ovitrel is an HCG. It's not an LH product, and so we start also by hypo with HCG and recombinant FSH or HMG when the financial issues are there. But we also don't use the recombinant LH therapy in our country.
Yeah.
This is a very good comment and very stimulating discussion. And not only for the field of infertility, we have we are preparing a publication. This is a PhD of a member of a SUO. Dr. Seminis is a member of a SUO. So in males who cannot use PD-5 inhibitors because of low testosterone, when they desire to be fathers, the solution is to give recombinant LH, to give Ovitrel, because administration of testosterone will have a contraceptive effect. So we have to think that Ovitrel is a very important substance And it may have a direction, as you and Zsolt and Marie said, for male infertility, but also for erectile dysfunction. Thank you.
So maybe you can comment on the next question, which is the combined use of HCG and testosterone preparations possible in men planning to conceive? I know the answer, but please comment on that.
Thank you. Yes, the answer is there are some studies that tend to suggest this thesis, but actually we don't have, Marie may correct me now, please Marie, give us a comment. There are no, because I reviewed the paper recently, there are no randomized control studies comparing two different approaches. With the permission of Photios, Marie?
Well, just very shortly, I agree with what you stated, Nikolaos, and I have no further comment.
Then we have another question saying that what about COVID and male infertility? Do you have any data about this? Well, I personally published a manuscript on that. Yes, we have some issues. Not great damage on male infertility, but it is associated with some cases on infertility. Of course, we have to wait for a few months after the infection to repeat the semen analysis. Is somebody else to want to comment on that? Yes.
We see the same results in our patient population. And in addition, I also see that after vaccination, this damage to spermatogenesis is less prominent than somebody had just primarily COVID infection without any vaccination.
Photios, looking through the publications, it appears that the cytokine storm that is an inherent component of the COVID infection causes in a subpopulation of males severe damage also to the Leydig cell secretory function and spermatogenesis.
Exactly. We have combined damage in the testis, both in the exocrine and endocrine function of the testis. This is for sure. And then waiting for the office, for the EAU office to interrupt us, we can go on with the next question. In low LH and low estradiol with normal to low testosterone, do you recommend giving LH analogs? Is somebody willing to comment on this? Low LH, low estradiol with normal testosterone, if we recommend giving LH. Well, I would say yes. I would go with LH here if it is available in the market. There are many data about AZFC microdeletions in varicocele men with severe oligospermia. What do you think about early detection of microdeletions before varicocelectomy, especially in young men? Well, in this case, I would go with the men who are azoospermic or severe oligozoospermic. Only in these cases, I always go with a genetic evaluation, even if I see varicocele, clinical varicocele, and then I go to varicocelectomy, of course.
That's the guideline.
Yeah, it is guideline, exactly. Then we have a patient with testicular torsion, was operated 4 years ago, still in infertility. Why? So testicular torsion is a severe, is a cause of bilateral damage of the testis. And so we often see that a very long period remained inside the scrotum. The testicular torsion then can irreversibly damage the other testes. So, or it could be another reason of infertility independent from the testicular torsion. Somebody else from the panel want to comment on that?
I really agree with that last statement that you made. So I think that's also important to consider.
Well, we have exceeded the time for 16 minutes. I don't know if we want to finish here. It was a very nice session with very expert on the topics speakers. So I thank you all for your excellent presentations, and I hope to see you again in next. We will have another a SUO webinar next November. It will be about sexual new modalities on sexual disorders, and I hope to see you all there.
And Photios, we thank you very much. You are the connective link, associate member of the SAO board, chair of SAO. Thank you very much for your nice contribution. I would like to thank Professor Liatsikos, SU, Professor Rasweiler, our leader, EAU section office, the executives for adopting the idea to organize this webinar, and also to all the participants for their lecture. Thank you very much.
Thank you.